And now I would like to introduce Dr. Raghuraj Hegde. I got it wrong. Hegde, sorry. From Manipal Hospitals, Bangalore, who is going to talk about medial canthal deformities and their management. Thank you.
Yeah. Hi. So I'm going to speaking about medial canthal deformities. So some of the medial canthal defects reconstructions has been covered by Yaj already. So I won't be doing that. So basically, medial canthal deformities are one of the most challenging cases that we have in oculoplasty, because the blood supply is a little restricted and scarring is more in the medial canthals. And so in this presentation, I'll be speaking congenital anomalies and trauma. So the other, because cancer reconstruction has already been covered. So clinical significance, so basically the impact of the eyelid alignment and function, and also the effects of the tear films. So tear film distribution and drainage is indicative of how the medial canthus is, and the position of the medial canthus is very important for the tear drainage as well. And aesthetic considerations also, because it is right at the eye, it is sometimes quite dystopic. Medial canthus will have effect on the cosmesis as well. So just brief anatomy. So we have to be mindful on the medial canthus that there is a lacrimal sac at the medial canthus, and on either side of it there are two crusts of the medial canthal ligament. So this is very important, as we'll see in the other future slides, that this is very important to keep in mind while we are reconstructing these medial canthal abnormalities. So congenital medial canthal, the biggest one is that blepharophimosis syndrome. So this is a lady, just to demonstrate, I'll just give you a brief history of a 26-year-old lady with telecanthus, epicanthus inversus, ptosis and uriblepharon. So the purpose of this presentation, I will only be speaking about the telecanthus part of it. So I have adopted this technique developed by Kim Yoon Duck. So she's basically, there is no VY plasties that we've been formerly using. We've been using this medial epicanthaloplasty using a skin redraping method. And this paper is very important because this is the general theme of the whole presentation, where I use the same technique in trauma as well, post-trauma defects as well. So, so the surgery where basically we reduce the telecanthic distance with using and we refix the medial canthus to the medial canthal where we are supposed to have the medial canthal ligament. So the medial canthus is fixed, and then you can see that the caruncular is exposed, and you can see that the fold of the medial canthus is also has disappeared. So subsequently she had a second stage procedure for a ptosis correction as well. So this is how this medial canthal was reconstructed. So medial canthal injuries, very common, we see it all the time. We often see it in the setting of a canalicular injury as well. So in this particular case, it's quite challenging initially, because all the tissues were macerated at the beginning, and then we finally found that she had a double injury at the canaliculus. So the initial laceration was right at the puncta. So it's that makes it more and more challenging to keep a monocanalicular stent. So we did the procedure, did it as best as possible, but the patient came back with this medial canthal defect right at the canthus, and we can see right at the canaliculus. So you can see that I'm not sure if you're able to appreciate that there is a monocanalicular stent sticking out of the canaliculus right there. So basically there was some vertical pressure going down, as well as the vectors were going down, as well as because of the wound tension, it was getting pulled off. So what we did was a multiple Z-plasties, and then also a lateral canthotomy cantholysis to release the eyelid to the medial side. Then we did a DCR in the same setting, because that would we would be able to put a bicanalicular stenting, and that would help in keeping the medial canthus at the right position. So sometimes we have very complicated trauma in the upper and lower canalicles, or both are lacerated. So in these cases, I prefer to do a DCR at the same in the primary setting. So along with the reconstruction, because that aligns the eyelids in the correct positions, and so it be, and also the force with the intubation actually pushes the canalicles at the puncta right towards the medial canthus. So that is that's a good pressure to have. So we do a DCR at the same setting, and this is at the end of the case. And he healed up quite well. We of course did a lot of scar management post surgery as well, which I will be speaking about. Scar management I will speak about in my last talk of the course. Sometimes, so this is another case, but it had a little bit of different course as it went. So we did the same. By both the canaliculi were lacerated, and there was a big injury at the medial canthus. So we did a DCR at the same sitting, and we put a bicanalicular intubation. Immediately post surgery, she was fine. She was doing well, and her epiphora, there was not much epiphora, all that was not there. But about a year later, she turned up in my clinic saying that she's having tearing, and on closer examination, we saw that there's a medial ectropion. And so that medial ectropion is, there's pooling of tears in that medial ectropion, and basically there is a skin shortage as well in the anterior lamella. So what we did is I redid the DCR because she was having blockage as well. So when we did the DCR, and we put the medial canthus in the position, and then there was a defect at the lower lid. So when the defect was, basically we reconstructed it with the advancement flap from the lateral lid. And so this is how it was, and post surgery her epiphora was resolved. It's not perfect, but at least her functionally she is happy with it. This is another medial canthal injury, dog bite. So in our part of the country, we get a lot of dog bites, especially in small kids. So this is during the COVID time. So we went in for an emergency surgery. There was a big hematoma at the medial canthus. So I drained the hematoma, did the primary suturing. So at that time I was not sure, because of all the edema, we could not see where if the medial canthal detachment had occurred. The patient was lost to follow-up because there was a COVID-19 pandemic going on at the time, and the patient next presented 2 months later with epiphora and mucus discharge coming from that the right eye. And on CT scan we could see that there was a mucocele that was forming. So basically the initial injury had damaged the NLD as well. So that is the reason for. So I used the same technique that we use for blepharophimosis with this skin redraping method. So we use the same incision to do a DCR as well. So this is so we go ahead and do a DCR at the same incision as the subciliary incision. It's much easier in kids because the distances between the subciliary incision and the sac is quite small. So we do a DCR, and then I reattach the medial canthus back into position. And this is at the end of it. She healed quite well with the medial canthus back in position, and also the epiphora was also resolved. So another complex canalicular, which again a dog bite injury, a 10-year-old girl who came. So she had a lower canalicular injury. So I did not go ahead with any DCR at that time because the upper canaliculus was fine, and I could feel that I could retrieve the dye from the under the infirmatus. So the sac and the NLD was normal. So we did a monocanalicular stenting and repair of all the skin and eyelid wounds at the same time. And so this is there was eyelid margin tear. So we did the suturing, and post surgery she came with a dystopia. So she didn't complain of tearing, but she complained of this dystopia, and that it was quite, you can see that it is not in line. So it's not at the same line. So what we did was similar to what was done, but here we didn't do a DCR. We just did the medial canthal fixation to the medial canthus. And we use the same subciliary incision and supraciliary incision, the vive-shaped incision. So the scarring is much lesser, and it's aesthetically more pleasing. So, so we reattached it back, and then this is at the end of the case. And so post surgery, you can see that the canthus is back in position, and the red line shows that it's back in position. Of course, we did a lot of scar management with 5FU injections and 5FU injections and the scar creams like silicone gels. So in summary, medial canthal deformities can be varied in presentation. It can be congenital, traumatic, and like post cancer as well. And meticulous planning and preoperatively planning it is very important. And also sometimes we have to take some decisions on table. And identifying the anatomical landmarks and knowing the anatomy is very important. Knowing where the medial where the anterior crux and the posterior crux is there, where the lacrimal sac is there, that awareness is very important. And some of these cases we need to do multiple surgeries. There is scarring and vascularity and infections post surgery, so we have to be very careful, especially dog bites. The infections is a big problem, and patient expectations needs to be better managed. Thank you.